Ischemic cardiomyopathy, or heart failure caused by reduced blood flow, is a leading cause of heart failure. It is characterized by a severely reduced left ventricular ejection fraction below 35% due to coronary artery disease. Revascularization options include coronary artery bypass grafting, a surgical approach often used for multivessel disease, and percutaneous coronary intervention, a minimally invasive alternative. However, the optimal strategy for patients with severe ischemic cardiomyopathy remains unclear, as most studies focus on broader populations without severe left ventricular dysfunction. This study compares long-term survival and secondary outcomes of these two approaches to guide management for this high-risk group. Let me know if you'd like further refinements. Detailed narration script for each slide of your PowerPoint. Quick takes on revascularization in ischemic cardiomyopathy. In this study of ischemic cardiomyopathy, or ICM, patients with severe left ventricular dysfunction, defined by an ejection fraction less than 35%, revascularization with coronary artery bypass CABG was associated with better long-term survival compared to percutaneous coronary intervention, PCI. Over a 10-year period, those who underwent CABG had a significantly higher survival rate than those who had PCI, which is crucial for patients in heart failure. However, while CABG provided a survival advantage, it came with substantial risks. CABG patients had a significantly higher risk of periprocedural stroke, almost 20 times greater compared to PCI patients, and also experienced longer hospital stays. These findings underscore the importance of considering both survival benefits and procedural risks when deciding on the optimal revascularization strategy for patients with ischemic cardiomyopathy. Study objectives and key question. The main objective of this study was to evaluate and compare the long-term survival outcomes and secondary complications of coronary artery bypass grafting, CABG, versus percutaneous coronary intervention, PCI, in patients with severe ischemic cardiomyopathy, specifically those with a left ventricular ejection fraction of less than 35%. The key clinical question addressed by the study was whether CABG or PCI offers better long-term outcomes in terms of all-cause mortality and secondary complications, including periprocedural stroke, myocardial infarction, kidney injury, and hospital length of stay. This study helps inform clinical decision-making by providing comparative data on these two treatment strategies in this high-risk population. Study design and methods. This was a prospective, observational, multi-site study utilizing data from the Australian and New Zealand Society of Cardiac and Thoracic Surgeons and the Melbourne Interventional Group registries. It included adults with severe ischemic cardiomyopathy, defined by a left ventricular ejection fraction of less than 35%. The study excluded patients who had ST segment elevation myocardial infarction, cardiac arrest, cardiogenic shock, or previous cardiac surgeries. The study evaluated outcomes from procedures performed between January 2005 and 2018. The primary outcome was all-cause mortality, tracked for up to 10 years post-revascularization. Secondary outcomes included 30-day mortality, length of hospital stay, and complications such as periprocedural stroke, myocardial infarction, and kidney injury. To ensure a fair comparison between the two treatment groups, the study used propensity score analysis and inverse probability of treatment weighting to adjust for differences in baseline characteristics, procedural indications, the extent of coronary artery disease, and left ventricular ejection fraction between the CABG and PCI groups. Study results, patient characteristics and outcomes. Of the 2,042 patients included in the study, 1,451.1% underwent coronary artery bypass grafting CABG, and 591, 28.9%, underwent percutaneous coronary intervention PCI. Patients undergoing CABG were generally younger, had more severe coronary artery disease, and presented with worse functional status than those who received PCI. For example, CABG patients were more likely to have multivessel or left main coronary artery disease and a lower New York Heart Association NYHA class compared to PCI patients. After a median follow-up of 4 years, the study found that CABG was associated with significantly better long-term survival. Specifically, 10-year unadjusted survival rates for CABG were 51.8% compared to 45.7% for PCI, And after adjusting for baseline differences, CABG was associated with a 41% reduction in mortality risk compared to PCI, HR 0.59, P 0.001. In terms of secondary outcomes, there were no significant differences between CABG and PCI for 30-day mortality, paraprocedural myocardial infarction, or kidney injury. However, CABG was linked to significantly higher risks of paraprocedural stroke and longer hospital stays. The odds ratio for stroke after CABG was 19.6, P 0.001, and the average length of hospital stay was 3.58 days longer for CABG patients compared to those who received PCI. Study limitations. Despite the robust methodology, there are several limitations to this study. Firstly, there were unmeasured confounders, including factors such as patient frailty, the presence of lung disease, or other life-limiting comorbidities like active malignancy. These factors were not collected and could have influenced the treatment selection, potentially leading to a bias toward PCI for patients with a perceived shorter life expectancy. Another limitation was the lack of data on the anatomical severity of coronary artery disease, such as the syntax score and the completeness of revascularization. This made it difficult to assess the quality of revascularization between the two groups or to compare angiographic findings like the presence of diffuse disease or poor distal vessel targets, which could affect the outcomes. Additionally, while the study observed an increased risk of stroke with CABG, the relatively low number of stroke cases resulted in wide confidence intervals, making it difficult to accurately assess the precise magnitude of risk. Furthermore, geographic differences between the CABG and PCI cohorts may introduce bias, as CABG patients were from multiple countries in Australasia, while PCI patients were primarily from a single state in Australia, Victoria. However, a sensitivity analysis limiting both cohorts to patients treated in Victoria showed no significant difference in mortality outcomes. Lastly, the study did not account for the type or extent of medical therapy received by the patients, which could have an impact on clinical outcomes. Conclusions and clinical perspective. This study concludes that for patients with ischemic cardiomyopathy and severely reduced left ventricular ejection fraction, coronary artery bypass grafting, CABG, provides better long-term survival compared to percutaneous coronary intervention, PCI. However, CABG is associated with considerable risks, particularly a significantly higher risk of stroke and prolonged hospital stays. These risks should be thoroughly weighed when making clinical decisions, especially in patients who may have additional factors that predispose them to adverse outcomes. While CABG may be the preferred option for those who can tolerate the associated risks, it is essential to adopt a personalized treatment approach. Clinical decisions should take into account the patient's overall health, comorbidities, and ability to withstand the procedure. Discussions about the survival benefits and procedural risks of CABG versus PCI are crucial for empowering patients to make informed decisions that align with their specific needs and preferences. Clinical implications and future directions. The findings highlight the importance of personalized treatment planning, emphasizing the balance between the long-term survival benefits of CABG and its associated risks. Clinicians must consider individual patient factors, such as age, comorbidities, and functional status, when determining the optimal revascularization strategy. While this study provides valuable insights, there are still gaps in the evidence, particularly regarding randomized controlled trials directly comparing CABG and PCI in ischemic cardiomyopathy patients. Additionally, long-term data for PCI in this population remain limited. Ongoing and future clinical trials will be essential for refining the best revascularization approach for ischemic cardiomyopathy, especially in patients with advanced heart failure.